Hello, it's so great to be amongst people who are dedicating their lives to this issue of preparedness and response. And how we allocate the resources that we have in disasters, how we choose who gets the resources that you work so hard to organize and to deploy, of course, that is going to affect the outcome, who gets those resources. And how you choose kind of where you target them is a question that involves a lot of value judgments and has sort of ethical dimensions. So in New Orleans, for example, in 2005, the levee failures after Hurricane Katrina surrounded this hospital, Memorial Medical Center. And the hospital had critical electrical equipment, where? In its basement, yes. And of course, the city below sea level and vulnerable to flooding. So helicopters did start to arrive, but these helicopters could take maybe 1 or 2 patients at a time. And this hospital had about 250 patients. It had about 2,000 people inside of it, doctors, nurses, staff, and family members. So this question of where do those critical resources go, in this case, the helicopter, if you were in charge of making some of the decisions, how would you begin to make that choice? Who gets on those helicopters first when you know that you're a hospital, a modern hospital that could lose power at any moment? So do you choose, for example, the babies? There was a neonatal intensive care unit, maybe because babies are so vulnerable. So you would want to help them out first, or they rely on a lot of power, which is the resource that you're about to lose in this hospital. Or maybe simply because there could be an ethical argument that children haven't lived as long as other people, and we all sort of deserve as many innings of life as possible. So, or would you perhaps look to help some of the older intensive care unit patients, maybe because they've given so much to society already, or there are people who depend on them. Also, they too need a lot of resources, which will be in short supply if the situation gets worse. Would you perhaps want to help people who could sit up, like these people in these wheelchairs, who could perhaps move more quickly, get to your staging areas more quickly, who perhaps would have a better life expectancy in the long run? So would you want to prioritize some of them first? And then there are all the people who are filling the hallways, the visitors, the people who've come from the neighborhood, even seeking help. You had people boating up to this hospital. You had also just the healthcare workers themselves, who will be a critical resource for the recovery. And we talk about how that's the long tail of a disaster. Some of them had chronic health issues. Some of them were very vulnerable. Of course, it was very, very hot in New Orleans in 2005 when this happened in late August. And there are even healthy children, and the staff members who brought them along to the hospital really wanted them to be rescued, wanted them out of harm's way. It was distracting them from their work to be worrying about their kids. So how do you begin to make these decisions? Obviously, a great example of where there are so many ethical dimensions, so many dimensions of values that come into these choices. Even the question of who gets to make that choice is one that has ethical dimensions as well. What happened in this situation was that some of the people who could move more quickly were put onto boats that were coming up to the entrance of this hospital. The water was rising that high. And then intensive care unit patients, including both the babies and the adults, were sent out on some of those first helicopters for some of the reasons that I mentioned. But there was also a very important decision that was made early on, which was not only which patients would go first, but that a category of patients would go last. And these were some of the sickest patients, in fact, patients who had so-called do not resuscitate orders. And so these were the patients who were there when, in fact, the power did fail. And each patient was put through a hole in the machine room wall and had to be carried up flights of steps to the helipad. And so as this was happening, hours were passing, and ultimately the power failed inside of the hospital. And that's when the situation became very dire, as you can imagine. There were staff who were hand pumping oxygen into the lungs of patients who relied on mechanical ventilators. And time was ticking by, and the helicopters, of course, had a whole city to triage and decide who to prioritize. Was it people who were waving, towels off of their rooftops, who might not have water, who might also have chronic conditions at home? Or was it going to be this hospital, which, should be able to shelter in place for a while? But is that realistic when a hospital loses power? There were the boats coming up, and slowly the hospital was beginning to get people out, but it was taking so long. And then there were the patients who were just lying there on the level of the parking garage just below the helipad, waiting and waiting for rescue. Some of these very sick patients with the do not resuscitate orders. And they were getting sicker and sicker. And there were some staff members who concluded that some of them just really didn't have a chance of survival at that point. And then the second decision ended up coming into play, that some people raised this question: could it be okay to hasten their deaths while they were assuming that these patients just could not be rescued and everybody else had to start getting out? And it was, as you can imagine, a very, very controversial question, even in the moment. Obviously, for us here, we're in a comfortable room. It's hard to put ourselves in that place. But even in that place and time, there were some staff members who said, absolutely not. This would violate the fundamental principles of medical ethics and nursing ethics. And others who thought that it was the right thing to do at the time. A disturbing photograph, but there were about 24 patients who received a drug combination of morphine and a fast-acting sedative called Versed, one or the other or both, in a very short time period, just a little over a day after the power failed. That's how desperate the circumstances became. And ultimately, this became a wound in the city. In fact, 2 doctors explained to me that they did, in fact, hasten the deaths of their patients intentionally. Another doctor and 2 nurses were arrested and accused by the Attorney General of having hastened the deaths of patients like the one you just saw, Emmett Everett, who wasn't even a terminally ill patient, but in fact was very heavy. And the staff told me they thought that he would be very hard to move. So ultimately, there was a press conference, and the Attorney General announced that he had arrested 3 healthcare providers, healthcare professionals, on second-degree murder. And ultimately, a grand jury did not indict these healthcare providers who maintained their innocence, and that was the end of the legal case. However, there's been a long tail, and many people in the preparedness world, many people in the healthcare world know about this story, have grappled with its implications, and certainly have thought a lot since then about how we should think about preparedness. There have been numerous actions. Obviously, the people who are officially in charge of thinking about emergency response, like many of you watching, are the ones who think about this on a day-to-day basis. But we know that, in fact, it's often regular people who preparedness is not their main job, who end up being on the front lines having to make some of these decisions. So there's been a lot of thinking about how to prepare them better for making some of these tough choices about where resources should go in the midst of a crisis when they're limited, like a helicopter landing on a hospital rooftop. So it's included everything from experts at what used to be the Institute of Medicine, now the National Academy of Medicine, gathering, looking at this case, saying, well, we believe that DNR orders, end-of-life preferences, a DNR is do not resuscitate, don't restart my heart if it stops, that shouldn't be used as a triage criterion. First, because it doesn't necessarily predict for somebody who will or won't survive. And second, because it's hard enough to get people to focus on their end-of-life preferences without them thinking that a DNR will be used as a do not rescue. So that was one conclusion. Another, even in the midst of an emergency, that it's never okay to cross that line as a health professional and hasten death. That were two of the conclusions by an expert panel that came together at the Institute of Medicine about 10 years ago to look at this. Other things, preparedness grants for healthcare have included, at some points, the mandate that the localities think about triage and crisis standards of care, and how would they sort of triage, or, well, the word nobody likes to use, ration resources, for example, critical care resources or ventilators in a flu pandemic, when you have way more patients who need that resource than could possibly have access to it. So recognizing that is a question of values as much as it is medicine or preparedness and planning. There have been some efforts around the country to involve the larger public who actually can grapple in quite sophisticated ways with these questions and give feedback to officials so that they can make some decisions in advance about how to think about these very, very difficult and ethics-laden triage issues. These are just some of the things that have come out of, and of course, the federal government now requiring through the Centers for Medicare and Medicaid Services some basic minimum standards in disaster preparedness, in emergency management for all healthcare provider subtypes. So these are some of the things that have come out since that experience in Hurricane Katrina that was so searing for the nation in so many ways, including this tragedy at this one hospital. But while this is incredibly tough, life and death kind of stuff, it's very, very hard to think about. In fact, in some ways, thinking about how you marshal resources within a single institution is easier than when you think about what about having to do that across an entire population. In fact, what if the people having medical emergencies were scattered across a flooded county with a population of over 4.5 million people? That is the situation that response officials faced when last year in Harris County, Texas, which contains Houston, when Hurricane Harvey was coming and became Tropical Storm Harvey and just releasing over 1 trillion gallons of water just in that one county. So you had the Emergency Operations Center. And so this question of where are our resources going to go? This was a county that is constantly being hit with flooding disasters. They had 2 major flooding disasters in the 2 years before Hurricane Harvey, so they had thought about this stuff. And one of the top emergency management officials said to me, our resources, our rescue resources in a flood situation are prioritized for people who are in life-threatening situations. That could mean fast-rising water, or it could mean somebody who has a medical crisis in the midst of a mass emergency, where a lot of people want to get out of their houses, but a relatively smaller proportion, a much smaller proportion, are actually in a life and death situation. So that is a reasonable triage decision. I think we could all agree. Who needs the resources the most? Let's try to marshal them and get them there first, because you don't automatically have everything you need all at once, and certainly they didn't in this case. But was the system set up to accomplish it? So if you are thinking, as you should, about how will I marshal my resources, who do I want to make sure get those resources, the second part of that is you have to think about, is my system set up to accomplish that? And so let's look at one person who was having a medical emergency and kind of go through the steps and see what it would take to get rescued in that situation. So this is Casey Daly, a mother, a 38-year-old mother who had surgery just a few days before Hurricane Harvey. She went home. Her home was well prepared. The electricals had been moved up. They lived in a trailer park, but they had done a lot of preparations. They are used to flooding there, and so they had stocks of water, and the county official, the city official for Houston and the county official for Harris County had urged the population to stay in place. So they followed what they were told and advised to do. But Casey had been discharged without a critical medicine. She had a hormone-producing tumor removed from her adrenal gland, produced the hormone cortisol, but she was discharged after the tumor was removed without that drug. And so as the floodwaters began to rise, she began to get sick. And this is Casey, mother of 2 children. So kids are in the trailer, she's there, she's getting sick. Floodwaters are rising, and after about a day, her husband says, I better call 911. So what does it take so that's that first step, identifying where somebody needs help. So his phone had to work. Fortunately, most of the cell towers did work because by the time Harvey hit Harris County, the winds were not so high. And so that phone had to work, and it did. It went to 2 call centers. First, the sheriff's call center, which had flooded, so they were displaced, and because they were on an analog system, which we still are in most of our 911 systems, they couldn't just flip a switch and have the call go to an unaffected area. They actually had one physical backup location. So that's where the call went first. And so let's hear just a bit of that call.
Okay, do you need medical or is this for a water rescue?
This is for a water rescue. My wife recently had surgery last Wednesday. She had a tumor removed from her left kidney, and she has been very sick. She's been vomiting for the past day and a half constantly, and she's in severe pain. And I don't want her to get into this water in her sutures. She needs to get airlifted to a hospital. Okay. I do know that Coast Guard is out doing air rescues right here in my neighborhood.
Right, I don't probably have to get you over to the EMS in order to get that. Let's talk to South Lake Houston EMS, let them know what's going on, okay?
So it's going to a secondary call center now that dispatches for fire and EMS. This is a common system in 911.
County transfer for, I guess, medical and water rescue.
Okay, for water rescue?
Yes, my wife recently had surgery last Wednesday. She had a tumor removed from her left adrenal gland on her left kidney, and she's been vomiting for the past day and a half. And
okay, how many people are in the house?
I have 2 boys and me and my wife.
And how old is your wife?
She is 38.
Okay, we do have over 1,000 calls for service in this area for assistance with evacuation. And as soon as the fire department is able to make it to this area, then you will be evacuated, okay?
Okay, thank you very much.
All right.
So the second call taker is at a call center that is just slammed with calls. There are, they've staffed up, usually 4 call takers. Now there are 8 call takers. They're, I think at this point we're 4 or 5 times their normal call volume. Somebody had come out, one of the leaders had come out to the call floor and told the 911 call takers to stop doing triage, to stop interrogating each caller, to sort of go through the calls and prioritize that as a medical emergency or not. So anybody in a flood area was basically categorized as a water rescue. So she didn't get that crucial information about the gravity of the healthcare situation and dispatched this to the fire department, the local fire department. Under the county's plans, that fire department was in charge of water rescues, but that small fire department had no boats. So they didn't really have the resources. Also, because they were getting so many calls for rescue, and there were about 5 fire personnel, they basically had all of those calls going into their computer dispatch, and they would have to click open each one to even read it, to even know what the details were, like that there was a lady who was sick. And they were basically focusing on one or another area. They had about a 70 square mile area. Most of it was flooded. So you can imagine that this call did not get prioritized. And that was the situation for about a day. What did he do? What's people's technology of choice now? Social media. So he went on social media, raised the alarm, his family raised the alarm, got on all of these sort of Cajun Navy and other priority lists for boat rescuers. Our systems could not sort of take in disaster calls for rescue off of social media. So that was another thing, this ability to identify who the people are who need the help the most. Can you actually do it? Can your systems do it? So it was about a full day later by the time that he got through to 911 after 4 calls. Finally, it was classified as a medical emergency. It was dispatched to the local EMS station, one of which it had two stations. One was flooded, the other looked like this. And they basically, medical was, ESF 8 was separate from rescue ESF 9. So that had its own system. And who could they call on? Well, the local coalition, except they didn't have boats or helicopters. They mostly were moving patients in and out of, flooded nursing homes and whatnot. So they had to rely on the fire department, with which they had a very sort of an old rivalry, as is true in many fire versus EMS departments. They did not set up a joint command, and they would have had to call that fire department. The fire department have to call the fire desk at the county emergency operations center and then ask them for some resources, try to get some state or federal resources. So any bit of that chain fails, there's no helicopter for this family. Well, and that's the EMS, and this is sort of the situation that they faced in their area. So what did he do? He was looking out the door. He heard a helicopter. This is his neighbor, and there was a helicopter that came for his neighbor. And so he ran up to the rooftop and tried to flag down this helicopter to say, my wife needs help. And that helicopter actually sort of seemed to hover above his house, his trailer, and then kept going. And he only found out later, how did this lady who needed dialysis, how did she get the helicopter? She actually had her husband, the owner of the trailer, he knew somebody who had a good relationship with a U.S. congressman and called the congressman, and an intern in the congressman's office had a federal official's phone number, arranged for this helicopter rescue. So that was the unofficial system working in a more efficient way for somebody who needed rescue than the official system that was in place to try to prioritize people who had medical problems. So long story short, what happened was that the unofficial system was what helped. The local EMS called, said, we got you on our list, we have no way to get to you, look out for any boat. And the husband of this lady, he saw a boat trolling past, he burst out the door, called for help. 3 boats, this is one of them, got them onto a channel, onto a flooded bayou, to a place where they knew that they had launched that morning, where some state Texas Department of Transportation dump trucks that had been just in time trained to go through high water had been waiting for hours for somebody to help. By that day, the waters had started going down, and in fact, very few people wanted rescue anymore. But communications, their radios only worked within their small team. They tried to find a hospital, they couldn't find their way there. Finally, they themselves called 911, got an ambulance. By that point, Casey's heart had stopped, and they couldn't bring her back. And she did get to the hospital, but after several minutes of performing CPR, they realized that she wouldn't make it, and she died by not probably ultimately because she lacked this critical medicine. So what can we take away from both of these tragic stories? I think it's just this realization to think very realistically about where you want to target your resources when you don't have enough. And you're going to be fighting to get more. That's so crucial. But in those early moments, how are you going to make sure that those resources have a good chance of getting to the people who need it the most? How are you going to think outside the box and think about the technologies that people used spontaneously, social media, and people getting online and creating Google Maps showing where people needed help? Are there ways that we can advance this in our own work, that each of you can think about in your realms, how to target those critical resources to the people who need them the most, so that we don't have a father without a wife, a son without a mother for the next emergency? Thank you. When we think about medical operations and sheltering, and there's been some effort to make sure that the drugstores can come and be a part of that, and certainly that was the case at the George R. Brown Convention Centers. One of the chain drugstores showed up, but and there was federal efforts to make sure that there would be reimbursements for those meds, and so that they could be given out. The supply could be given, I think, a 30-day supply, if I'm remembering correctly. But there are issues. They only perhaps had a limited pharmacy, and I'm not sure if they had all of the drugs that they needed. And we're also dealing very much with drug shortages, and that's a whole other issue that involves triage and prioritization. But I think you're absolutely right. Certainly in those shelters, people would show up, people who either have chronic mental illness, who didn't have their meds with them and needed them, or people who had exacerbations of mental health issues because of the stressful situation. So this is definitely, in my experience as somebody reporting on these disasters, is a critical issue that there's only now starting to be more awareness about. So thank you for raising it. The decision to hasten death, when that moves into a legal realm, I think there's the issue of medical ethics and what medical ethics says about it, which is no, generally, post-Hippocrates. But also, there's the legal aspect. So, of course, the prosecutors were uncomfortable because they were applying law to a very extreme situation, and they had prosecutorial discretion. They can always decide whether or not to bring charges in a case like that. And certainly the grand jury seemed to have a lot of sympathy for the health professionals. But also, there are laws. There are actual laws about that. When it comes to triage and prioritization and crisis standards of care, it's generally thought that you can, and there have been some efforts legally to build in some legislation that will support health providers who do follow kind of a standard that the medical profession has created. And so there have been a number of, I could point you to some sort of legislative efforts in various states. But you're absolutely right that there are health professionals who say, I'm not going to really change my standards so much because I'm afraid that I could be, brought up on some charges. So that there is a fear there. And I generally think that it's important for us all, when we think about disasters and changing the way that we may have to practice medicine in this example, but other really important standards that we adhere to always aim for the highest achievable standard of care rather than immediately galloping to the lower standard of care, because often you can be creative and find ways around some of the problems. This is not only about communications, it's about a lot of things, but it still is about prioritization, because if you are a top county official who says that my systems are in place to prioritize people who need care in a life-threatening situation, you have to look at whether the system in place will actually do that. And this system of so many steps to get to that resource doesn't quite make sense. There must be a better way to orient the system around getting those resources to people who need the help. It is critical. It is that link. And it's interesting, at some point, realizing how overwhelmed 911 was, the Coast Guard released their phone numbers to their local command to do their own triage. They started paper and pencil at first, writing down the names of people who were calling them directly for helicopters. So 911 was siloed. They told me at that call center that they couldn't dispatch a helicopter. They had no communications with the federal officials. They were even afraid to call the county EOC. They sent me a recording where they gingerly called the local fire department saying, hey, we just got a call, somebody's on the top of a car and we know you're nowhere near there. Do you mind if we call the county fire desk to see if they could maybe send somebody? They were afraid to even do that. So yes, better communications. 911, it's so localized, there's very little, there's federal guidance, but not a lot of regulatory authority on that. It's very localized. So bringing up 911, making those connections, look up FirstNet, That's sort of the communications link from sort of 911 to the responders, that dedicated broadband, part of the broadband spectrum that should allow better communications, and then upgrading 911 systems to something called Next Gen, which will be internet protocol based and be able to be more flexible in terms of forwarding calls and accepting multimedia and then forwarding that on to the responders at various levels. But there's so much work still to do. It's crucial. Harvey really has taught me that, wanting to target people who really need help, we need to invest more in these public safety systems and making them work. I think it's a discussion we all have a stake in, right? Any of us could need healthcare in a disaster, and so the broader the conversations around this, the better. And what we've learned in the last decade is that the public can handle it. And in fact, I would argue, of course, I'm biased being in journalism and writing, I want to say we should be as transparent as possible because you need the public as your partner in one of these situations. They need to understand what the likely scenarios will be. And people can wrap their heads around that, and they can make some really good, very sort of ethically sophisticated choices, and we need to listen to them. It's, those of us who are in this room probably have a certain set of ways of looking at the world that may be very different from broader segments of the communities where we come from. And you find yourself being surprised. I've gone to a number of these workshops that brought in the public, and the people who organize these, when they have open minds, they always learn something. They always think, oh my God, I never thought about that. Or this equity issue that will magnify itself if we do triage our resources in a certain way. We're going to be biased against this whole group of people we never even imagined. So this is really important to have these broad conversations, and I urge you to have them in your communities.